good afternoon. Today I am going to present the design and the initial findings of the REALIST study on microvascular complications in patients with type 2 diabetes. I will start with a very short background on the residual risk for microvascular complications in type 2 diabetes. Microvascular complications occur frequently in patients with type 2 diabetes, and the prevalence of these complications has been increasing in the last decades, and this is due to the improved survival of patients with type 2 diabetes. You have heard from before in the first presentation that diabetic nephropathy is the most common single cause of end-stage renal disease in Western countries. In the United States, 44% of the new cases of end-stage renal disease requiring renal replacement therapy, which means dialysis and transplantation, is due to diabetic nephropathy. Similarly, diabetic retinopathy is the leading cause of visual loss in adults in all Western countries, and diabetic neuropathy is the leading cause of non-traumatic lower limb amputations, accounting for up to 60% of the new cases in the United States. Thus, the microvascular complications are associated with very high morbidity and mortality. And this has a dramatic impact not only on the quality of life of patients, but also on medical costs. These are data from the United States demonstrating that a large proportion of the medical costs are due to microvascular complications of diabetes. You can appreciate here that among the total cost of the general population for neurological problems, 24% are due to diabetes, and among the costs for renal problems, 29% are due to diabetes. So a very big problem also in terms of costs. Now, in the last years, there has been an improvement in the management of blood glucose, blood pressure, LDL cholesterol in patients with diabetes. However, unfortunately, despite current treatments, the residual risk for microvascular disease is still too high. And this clearly emerged from the very important STENO2 study that I'm sure you all are aware of, that was published in 2003. In this study, patients with type 2 diabetes were allocated to conventional treatment or to multifactorial intensive approach. And this multifactorial approach included lifestyle intervention with the changes in diet and exercise, optimal blood glucose, blood pressure control, and optimal control of LDL cholesterol. The patients were followed for 8 years, and at the end of follow-up, patients who were on this multifactorial intensive treatment had a benefit in that there was a significant reduction in the proportion of patients who progressed to overt nephropathy. They already had some degree of nephropathy to start with, and a significant decrease in the development and progression of both retinopathy and autonomic neuropathy. So, very good news. However, if you focus on the light pink bars, you can appreciate that despite very intensive treatment, still there was a substantial residual risk for microvascular disease. You have heard before that in diabetes, atherogenic dyslipidemia is very common, which means that patients often have low HDL cholesterol and high triglycerides. And the field study has provided some interesting data on this regard. In this study, fenofibrate, which is a PPAR alpha agonist, which is able to increase HDL cholesterol and decrease triglycerides, was able to reduce the requirement for laser treatment, so a very solid and hard endpoint. So reduction in retinopathy, a reduction in the progression, in the worsening of nephropathy, and the reduction in the number of amputations. Thus, this data suggests that atherogenic dyslipidemia is probably important in conferring risk for diabetic microvascular complications. Unfortunately, we don't have epidemiological studies supporting this concept, and this provided the rationale for designing the REALIST study on microvascular complications. The objective was to determine whether low HDL cholesterol or high triglyceride levels are associated with a significant residual risk of microvascular complications after adjustment for other risk factors in patients at or near goal for LDL cholesterol. As you heard before, several studies agreed to participate in this study, and the controls were defined as patients with type 2 diabetes and at least one microvascular complication, mostly nephropathy and retinopathy, because neuropathy is very difficult to diagnose. They had to have LDL cholesterol of 130 milligrams per deciliter or less, with or without therapy. The controls basically had the same criteria, except that they had to be free of microvascular complications. I'm going to present today very initial data coming from a single center in Brussels from Professor Hermans. He was able to collect 195 cases and 190 controls. These are raw data. They have not been adjusted for variables, and they have not been matched. You can see that the cases, patients with complications, were older. They had a longer duration of diabetes compared to controls. They were more obese. The systolic blood pressure was higher. Metabolic syndrome was present in almost all patients with microvascular complications, 92%. They had a worse metabolic control. Interestingly, the similar proportion of patients were treated with lipid-lowering agents, around 65%. LDL cholesterol levels were similar in cases and controls, while HDL cholesterol was significantly lower in patients presenting microvascular complications, while triglycerides were significantly higher. Thus, high triglycerides and low HDL cholesterol are significantly more common in patients with type 2 diabetes and microvascular complications. We also analyzed separately the cases with nephropathy and those with retinopathy. 127 patients had diabetic nephropathy. Again, LDL cholesterol was similar in the cases and in the controls, while HDL cholesterol was much lower in patients with nephropathy compared to those without, and triglycerides were higher. For diabetic retinopathy, the numbers were much smaller. We had only 68 patients. Also, for this complication, LDL cholesterol was similar compared to the controls. There were no significant differences in HDL cholesterol, and triglycerides were significantly higher. Thus, from this initial analysis, we can conclude that there is suggestion that both nephropathy and retinopathy are associated with elevated triglycerides and/or low HDL cholesterol in patients with type 2 diabetes at goal for LDL cholesterol. We are currently gathering additional data from numerous countries, and once available, all the data will be sent to Boston to be analyzed. And I think this will provide some interesting data also on regional differences in the association between lipids and complications. If the final data will confirm the link between atherogenic dyslipidemia and microvascular complications, I believe that this could lead to substantial changes in the way we assess the microvascular risk of our diabetic patients, and also in the way we treat them. Thank you for your attention.